Welcome, everyone, to the first in our series of the Cystic Fibrosis Newborn Screening webinars. This will be on pediatrician feedback on CF newborn screening results. This project and our activities are funded by the Cystic Fibrosis Foundation. We're very excited to have you here. I am Marcy Sontag from the Center for Public Health Innovation. I am joined by my colleagues Joanne Keller-Gunther and Colleen Shannon, also from CPHI. And we're excited to be able to organize these webinar series and other activities related to CF newborn screening. Before we get into our prime talk today, I'd like to share with you some other resources that'll be coming up or other activities. Our next in our webinar series is a talk of the newborn screening sequencing and resource centers, which will be May 1st at 3 o'clock Eastern. I'll have more information about this at the end of the webinar as well, but I wanted to highlight that the CF Foundation is also funding sequencing centers to help state newborn screening programs with their CFTR sequencing. And we also are launching collaboratives for 2025 that are learning collaboratives for both CF centers and newborn screening programs to join together to work on improving their newborn screening for CF. We have an informational webinar next on April 15th, which I think is next Tuesday at 4 p.m. Eastern. We are looking forward to seeing many of you there as well. Please register in advance. And now getting into our talk, many of you know, or all of you really know, cystic fibrosis newborn screening, or newborn screening overall, is really a three-part process. The first part, the pre-analytic phase, where the red blood spot is collected and sent to the public health laboratory. The analytic phase, where the CF testing is done in the laboratory, both with immunoreactive trypsinogen and CFTR, either variant panel testing or variant panel and sequencing. And then finally, the communication of results to the primary care providers. This last section that we're going to be focusing on today. However, throughout the webinar series and our collaboratives, we'll be covering all of these different activities. I'd like to briefly talk about the cystic fibrosis newborn screening guidelines because they help to guide some of our activities throughout the collaboratives. They were recently published, and you can see that reference down at the bottom. And it was also, the link was just placed in the chat for you as well. I'm not going to go through the details of this. The cystic fibrosis guidelines cover all aspects of CF, starting at the top with the IRT measurement. The outlined boxes are those that are really focused on the recommendations themselves. So starting with the IRT, looking at the CFTR variant panel testing and sequencing. And then down at the bottom, we have the notification of the PCP and specialist. And it is that recommendation at the bottom left that we're going to be focusing on today, is that communication with the PCP and specialist. But as I said earlier, all of these activities will be covered through various different webinars as we move forward throughout the rest of 2025 and through our CF Learning Collaboratives. I'd like to draw special attention to some of the best practices for newborn screening that were highlighted in our guidelines. First, related to communication. Communication of a positive newborn screening result should involve both the primary care provider and the CF specialist. And the reasons why is the primary care provider has that trust with the family, and the CF specialist then can help with the details about CF. And developing that relationship between the two is really important so they know what their roles are. And Michele will talk more about that later on in our conversation today. Second, the education of the medical community is really important that we educate that that newborn screening is a screening test only. And if signs or symptoms of CF are present, that a diagnostic test should still be done, and this child should be referred for a sweat test. And that we should really educate that CF does occur in all races, ethnicities, and ancestries. So why do we know that communication is a challenge? A few years ago, we did a qualitative study interviewing both CF center clinicians as well as newborn screening programs. And I highlight just a couple of the quotes here from CF center physicians specifically, highlighting the challenges of that they see. First, sometimes the pediatricians will tell families not to come in for an evaluation. We'll just repeat the IRT somewhere down the road. So sometimes we don't see people and they've had 3 IRT specimens repeated, and then finally they come to see us and it's positive. So obviously resulting in a delay there. Second, a lot of pediatricians, especially in a certain part of the state, don't believe Hispanic patients can have CF. So maybe if only one mutation is picked up, they may drag their feet about referring the kid because of this misconception. So these are just 2 examples of the challenges we see with communication that really highlights why we need better initial communication with CF center or with primary care providers. Many of you know about the ACMG ACT sheets. ACMG is the American College of Medical Genetics and Genomics. Through the development of the ACT sheets that originally was done in 2006 for cystic fibrosis, these ACT sheets are designed to accompany the positive CF newborn screening result. It often states, adapt these ACT sheets, ACT is for action, adapt these ACT sheets to send with their newborn screening results to be given to clinicians to say, this is what you should do next. What are the actions you should take next for your newborn screening program? Really, they serve as a clinical decision support tool for primary care providers. So they know what those steps are to do. The ACT sheets were recently revised in 2024 with the CF newborn screening guidelines in mind. Knowing what was likely to come out in those guidelines, those ACT sheets were revised to reflect that. I have an example of the ACT sheets here. This is the ACT sheet for elevated IRT and 2 CFTR variants. There are actually 3 different types of ACT sheets, one for 2 variants, 1 variant, and no variants with a very high IRT. Highlighted here, I want to point out that we do comment in the condition description that CF is a multi-system disorder affecting all races and ethnicities, really helping to try to educate clinicians about that piece of it, that it is seen in all children can be affected with CF. And second, it highlights what those next actions should be. So you should take these following actions, and they're spelled out in bullet form. These are great. The challenge sometimes can be that this ACT sheet can get separated from the newborn screening result, or clinicians have many things to do and might not read through all of the details here. If you'd like to see more about the ACT sheet, you can go to the link that was shared earlier or through this QR code. There are ACT sheets for all the newborn screening disorders available here. So with that, I'm really excited to introduce Dr. Michele Gornick, who will be talking to us about her work with the Virginia Newborn Screening Program and pediatrician feedback on cystic fibrosis and newborn screening results. Dr. Gornick, take it away.
Thank you. Good morning or afternoon, I guess, depending on where you're calling in from. I want to first thank the Cystic Fibrosis Foundation and the Center for Public Health Innovation for inviting me to share some of the recent work that I've been a part of and sharing it at this Cystic Fibrosis newborn screening webinar series. So it's like a lot of words to say at one time. Okay. Okay, so I want to set the stage here first by telling you what I am not and what I don't do before telling you about what I actually do. The great news is that I work with an amazing team of people that include everyone you need to have a successful team and to actually do this research. Okay, so what I'm not a pediatrician, but my wonderful collaborator, Beth Tarini, is. I am not a screening program supervisor, which another fantastic coworker, Mary Lowe, is in the state of Virginia. I'm not an expert in newborn screening who has years of experience in the laboratory and other aspects, or probably almost all aspects of newborn screening, which Ann Atkins is. And I'm not the person who magically gets everything done on the technology side and implementing things, which is Kelly. Kelly has many skills, but I would say one of her most helpful ones in this project is sort of, I need to do this thing and I don't really know how to do it and implement it into the program, and Kelly does that. So who am I? I am a geneticist and a statistician by training. But I think, the best way to describe the work that I do and what my real passion is kind of where in newborn screening, I first encountered newborn screening. And that was during my fellowship training where I focused on communicating health information and medical decision making. And so the thing that I'm really passionate about and what I hope you'll see is part of this work is how do we best communicate complex information, specifically genetic information, since I'm a geneticist by training. And in this case, it's focusing on genetic and molecular test results in a newborn screening report that's in a way that's understandable and usable as part of the communication process. So I really like to think of myself as a methods person. And by that, I mean, I'd like to, once we know what the question is, figure out what is the best method to use to sort of answer that question. And sometimes it's statistics, sometimes most of the time it's not. Sometimes it's using different methods, and you'll hopefully, I'll convince you by the end of this talk that we chose the right method to do that. So let's dive in here. So this work is part of a larger project in collaboration with the Virginia Newborn Screening Program and also Children's National. And it's part of a grant funded looking at unresolved issues in newborn screening, mostly focusing on the harms of false positive results, but part of this grant was a sub-aim that really wanted to focus on communication to primary care physicians and how we can sort of improve that process. Okay, so the part of the grant and project that I was focused on and had a role in is looking at this question about whether or not do newborn screening results reports meet the needs of providers that are using them. And Marcy did a wonderful job of sort of setting me up for this. And really, you know, the punchline here is probably not. We're probably not doing the best job that we can. So today I'm going to go through how can we address this problem? What's the best method? And why do I think this is the best method for looking at this problem and hopefully coming up with some good, good improvements? What we did, what the providers said in response to what we did, and then kind of things that we can do sort of moving forward to wrap it up. So how can we address this problem? One of the methods that I'm a really big fan of and that we decided to look at for this project was something called user-centered design. And I would say we sort of adapted this and used principles of user-centered design in this project. So what is user-centered design? It's a iterative design process in which you engage the user. So in this case, it was the providers, the pediatricians, the midwives, the specialists that actually receive these reports, and focus on the users and their needs, goals, and challenges. And they are part of the entire process. So sort of from the question to actually designing and using the test report in this case. And the idea here is that if you engage the user throughout the process, this will facilitate usability and hopefully satisfaction with your product in the end. And that was why we thought this would be a great method for this question in particular. Okay, so what do we do? Just to give you kind of an overview of the project, well, the first kind of step in this process was researching best practices for communicating test results information. And yeah, there's not a whole lot of research on specifically genetic test results, but I think there is some about what are kind of the key format and design issues and how to communicate test result information to people that are using a test report. Next, this is where the the Virginia Department of Health and Mary Lowe was a integral part of this project, but it was really inviting the providers in the state of Virginia. So this was pediatricians, midwives, nurse practitioners, specialists to be a part of this project. And I really want to shout out Mary's relationships and amazing desire to have like improved communication with everybody in the state that is part of this newborn screening process. And I think that was really why this was so successful, this part of it, because I think this would be really hard to get pediatricians to take an hour of their day to talk with us about this. And we had such an overwhelming response. And it was really great. And I really credit that to Mary. So then we sort of engaged with 20 different providers to do these interviews. And this was a time commitment for them. So it was really great to have that great of a response. We had 10 specialists that participated in the interviews, 8 pediatricians and 2 midwives. And then the next part of the process was kind of this redesign. I'm going to talk a little bit about like the design template and then the interviews and what we asked the pediatricians and the specialists. But then what we did was take their feedback. We did some qualitative analysis, took their feedback, incorporated it into another iteration of the report, came up with a new design based on that. We've kind of just finished that process. That's why I kind of have this like star at that part in it. And then we are planning on doing follow-up interviews with providers to see if this redesigned report with their feedback and their input is improving usability. So that's kind of the next and final step of this process. So I wanted to show you this and kind of point out a few things. So on the left-hand side here is I would say sort of the current or the old newborn screening report that the state of Virginia uses. And I think we can all agree that it looks like just sort of like your average typical report. So this is not to say Virginia like is unique and needed this, theirs redesigned and nobody else did. Like it's very brave of them to allow us to just sort of like take it and like do whatever we wanted with it and make it new and fancy. So thank you again to Virginia for letting us experiment with their report. That to the left is sort of, it was the report that's currently being used in the sort of old report, I'll call it. And then the right-hand side is what the design template was. The other thing I really want to point out is this is just sort of like the cover sheet. It's the first page that whoever receives the fax, which is the specialist and the pediatrician in this case. And there's a lot more that they receive. So they receive fact sheets that have links to like, information. Both the provider and the parents have a parent education fact sheet. And those are available at the Virginia Department of Health website if you want to look at those. But there's many other pages that come after this. We really just focused on redesigning this first page, which is the first thing they encounter. Okay, so what I wanted to go here is just really point out quickly what I mean by some of the like design changes and things that we moved around, we redid based on best practices for communicating information. So the first thing is this action item. It's what's going on here. And if you can look at the left-hand side where I have it boxed, telling the pediatrician that there was a critical value or like something was wrong here, this was not a normal result, it's kind of like buried in the title and not very obvious. So we took that, we made it big, and we put it in the front in a box, on top. The finding. So again, the finding kind of feels a little bit buried here, and we know that we should have that up at the top first center. All the very important information should go first. Recommendation, we felt like there was a lot of verbiage, jargon, terms, things in here, wording that we could kind of like pare down and just get the central message here and put the recommendation there. Next steps. So we really want it to we're trying to improve communication and improve this process of handing off patients to the pediatrician and then the specialist and back to the pediatrician. So we really want, and to the state, and we really want it to be very clear what they need to do. And then demographics. This is probably one of the hardest things I think for practitioners and providers to get used to, but putting, if you're used to seeing your test report, you're used to that being all up at the top. And really, that's the stuff that you can access at some other point, and we should be moving it to the bottom. So that's kind of another design issue that I wanted to point out. Okay, so in terms of the interviews that we did, they were designed to be about 15 to 20 minutes. I think on average, they were probably closer to a half an hour. We did allow like an entire hour time slot. I think the good news is that they were on average a half an hour because the providers really were engaged and wanted to talk with us. And that is great, especially when you're collecting data. You want as much talking as possible so you can get lots of information from people. So what we kind of asked them for kind of, I don't know, topics. And, one of them was really just like, can you tell what this report is about? Like, what is this report for? And again, that might seem silly, but we really wanted to make the answer was not always yes, I can tell exactly what this is about. So that's important. If they're not getting what is this report, then, that's a problem. The next big thing was, can you find where the essential information is located? Can you find, is this a normal or is this an abnormal screen? Can you find where the finding is? Those sorts of things. What do you need to do next? Another topic that we really wanted to get at is, what is the difference in their opinion between screening and clinical results and reports? And should the report look different if it's a screen versus a clinical test result? And then really kind of like, how do you use the report? What do you do with it? I'm not going to go through all of these things today and in all the different sub areas, but I just wanted to let you know that we asked, these were sort of the domains that we were really interested in. Okay, so what they said, I'm going to present this in sort of two different ways. The first way I'm going to sort of present this is all the pediatric providers. So what did the pediatricians, we had 8 pediatricians we spoke with and 2 midwives. So I'm grouping those as pediatric providers. And then I'm going to talk really specifically about the cystic fibrosis test report receivers. But first, this is just the pediatrician or pediatric providers. We randomized the providers that we spoke with to receive one of 4 different test result reports. And this was for a variety of reasons, but one of them was because, and I'll show you an example, the different conditions and there are many different conditions that are screened for, have different senses of urgency, different things that you need to do, different types of follow-up. So we kind of wanted to get a sampling of like, does that matter? And does that sort of change how the pediatrician interacts with the report? So first I'm presenting to you what the pediatric providers said to us. Okay, this is where I want to show you. On the left-hand side is the template that was given that is the cystic fibrosis report. And on the right-hand side is the one for SCID that we gave. And again, you can see they're very, very similar. There's just a few different sort of nuanced things between, like, that are, when you compare the cystic fibrosis report to the SCID one, and one being like what you should do next in the next step. So again, that was just to give you an example of like why we had different types of reports that we randomized to. Okay, so what they said, the pediatric providers, first kind of theme that we found when we did the qualitative analysis was this idea of what I'm calling triage first and think later. So the pediatric providers scan the report first for whether or not there was an abnormal result or if it's normal. And then once there is something that is not normal, that sort of drives the decision-making process. The second theme that we found, I'm calling simplify the action. So the pediatric providers are looking for clear next steps rather than detailed clinical information. So they do not want or feel like they need to know all of the details about what exactly the value was of the test report. They really just want to know, is there something I need to do? What is it? Design matters. So one of the things that I'm calling as design matters is if there is a result, where does it appear on the report? And this overuse of jargon often hinders the usability for pediatricians. So they're not always familiar with a lot of the terms that we see every day and we use all the time in newborn screening and especially related to like test results. So the design process does matter for them. And then this fourth theme I'm calling who is on the hook. And by that, I mean, who owns the follow-up process varies across setting and experience. And really, I think we're getting at here is who closes the loop on this. So you receive this report, it goes to a pediatrician and a specialist, it's coming from the state. Who is supposed to start the next part of the communication process? Who then, after they do something on the diagnosis side, reports that back to the state? And there is some confusion on whose role it is, and people that don't have as much experience with this process don't know who the next person, what they should be doing in the follow-up process. Okay, so I'm going to give you some quotes that kind of illustrate these different parts of the process, or different themes that we came up with that the pediatric providers said. So the first one, to triage first, think later. So someone said, we immediately go for the abnormals because often a lot of these kids have lots of labs and we're screening really quickly. Another pediatrician said, definitely abnormal screen just pops out. And that's what you want. You want normal, abnormal. Normal's sweet, I go on with my day. Abnormal, well, let's think this through. So the next theme, simplify the action. One pediatric provider said, the next step section is particularly helpful to me, especially since these are unfamiliar conditions to me. Another provider said, I go right to that box of next steps. I love that because it's like, okay, what do I do next? Design matters. This one I like, and I want to highlight that I put a sort of what I would call a positive quote and maybe a sort of a negative, or like, how can we improve feedback? Because I think that's really important to think about when you're doing design and when you're working as part of this process. Is sometimes the sort of like critical feedback actually is the most important for designing the process or improving the process. So the first person said, too much verbiage makes older reports hard to read. The new format and layout simplify the interpretation. Another person said, yeah, this format is not as clear as it could be because it says critical in small letters and then it says abnormal in big letters. And I think that quote, for me as somebody who's working to improve the design and communication process, was really key, because using different words, different terms in different contexts, and even just, one's big, one's small, is really confusing. And I don't, think that I don't think we would have realized that unless somebody said that. So that's an example of why that's really important. Okay, who's on the hook? Nobody is quite sure where they fall into the accountability ladder. Someone else said, pediatricians care about next steps. Specialists focus on numeric values to triage decisions. Somebody else said, I don't know what to do next, other than I have to wait for somebody to call me or tell me what to do. So hopefully these kind of illustrate some of the different themes that we came up with. So now I want to present the subset of the data analysis that we did just on people that received the cystic fibrosis newborn screening report. So as I mentioned, there were 4 different reports. We kind of randomized all the interviews to those individuals. Now I'm just going to show you the people that just received the cystic fibrosis report. So that included 4 pediatricians or individuals that were in family medicine or family medical practice, which were, there was 4 of those individuals. We had 1 midwife who received the cystic fibrosis report, and then 2 individuals who worked at a CF center. So I'm calling those specialists, CF center specialists. Okay, again, just to refresh your memory on what the CF report template looked like, the first kind of redesign template. One thing I want to point out here, because I think this does impact the theme and kind of what we found a little bit and what people said, was this report has a spot for like 2 mutations listed. And I'm sure most of you know and are well aware, and Marcy went over this in the beginning, that there are different guidelines and different things that you do if you have an individual that has 1 mutation versus 2 mutation. I don't think we really did this intentionally, put a 2 mutation report on here, but that does, I think, influence the response to this a little bit. Okay, so what did providers who received the CF newborn screening report say? The first thing that we sort of theme that we came up with was this first glance functionality. And by that, I mean how the information is visually structured. So what appears first, what's bolded, that sort of thing, what draws your attention to the report matters. The second theme was the urgency signal. I'm calling it the urgency signal. So this theme, I would say, is sort of this desire for stronger signals about whether results were urgent or just sort of a routine result. And I'm going to go again through some quotes to hopefully illustrate what I mean in these themes to help you get a better sense of that. The third theme was this action-oriented guidance, I'm calling. So that is the CF clinicians really wanted reports to tell the pediatricians exactly what to do, who to contact, and it came up several times, sort of this how fast. So they didn't want just sort of, this is urgent or immediately. They wanted really information on like, what do we mean by fast? Do we mean like 24 hours, 48 hours, call today? So that really like a little bit more detail there. And then the fourth theme that came up with providers who received the CF, specifically the CF report, was this sort of concern that families and some providers may misinterpret screening results. And again, I'm going to go through examples of those right now. So this first theme of first glance functionality. And here I am actually designating whether or not what their actual role is. So if it's a pediatrician, if it's a CF specialist, or if it was one of the midwives, just to give you a little bit more context. A pediatrician said the abnormal is boxed and at the top. That's the first thing I noticed. Someone else, another pediatrician said, oh, sorry, my screen just started moving on its own. There we go. Sorry, I must have clicked something. Okay. Letting me know, yes, I need to refer. No, I don't. Having that really clear is helpful. One of the CF specialists said, I don't think there would be any question about what the recommended next step would be. The urgency signal. So this is the second theme. Consultation sounds very elective to me, but this needs a very high level of immediacy. So this was one of the CF specialists said, this quote. This CF nurse specialist that we spoke with said, this is a T mutation, which is the easiest, I think. And that's not critical, and that it's critical and that it's abnormal. I think that there's more confusion when there's just one mutation. Action-oriented guidance. So this theme, this is one of the examples from one of the midwives, was next steps, who to reach out to. That really stood out. A pediatrician said refer, just because it says next steps, and it had it checkboxed. So they really liked that it's credited this is what you do next, very simply laid out. Screen, not diagnosis. So I think I have two different slides here for this because the quotes are a little bit longer, but this was in response to the question, the way it was sort of worded was, how was a screening result different than a clinical result? And this individual said, in most cases, you have two mutations. You're dealing with an individual who's going to be living with cystic fibrosis. We can't predict symptoms. Indicating the possibility, I think, leaves false hope. A pediatrician said, and again, this is kind of in response to how is a screening result different from a clinical result? Whether it's diagnostic or screening tool, these are things where we say, okay, is it normal? Is it abnormal? If it's abnormal, what is the next step in either figuring out what is the next step in clinical management? I would treat this screen just the same as a blood sugar of 112 or an A1C of 12. There's something we need to do to intervene for a health concern, and that's it. Okay, so that's a whirlwind tour of some of the feedback that we got from the providers. And I want to just show you kind of how we took that and implemented it into that next step. So that was kind of like the second iteration of the design process that we are just in the, sort of completing and then moving on to say, okay, we heard what you said. This is how we interpreted it. And this is what we did. Do you like this better? Or like, what can we do? And so this is in response to the provider is talking about the action item and how they found that it's a little bit confusing to use jargon and different terminology, or maybe I should say it's how important it is to be really clear in the use of words and terminology and not interchange them. And I think I, gave a quote earlier that was talking about how, is it normal? Is it critical? You have it big in one spot, little in another spot. So in the provider's minds, there's 3 different categories. There's normal screen, abnormal, and a screen and a critical screen. So for them, this is a quote they said, critical is critical. Abnormal, it's not nothing, but it's different. Another individual said, it says critical and then it says abnormal and then it says results, critical group, critical ratio. In the newborn screening world, there's a big difference between abnormal and critical. So this was something we felt like was important to address in the report. So, okay, on the far left, this is where we started what again, I call old newborn screening report, but it's kind of currently soon being phased out. And then we had our template, which had this, we rearranged, did a lot of different reformatting, rearranging of the report and where the information lies. One thing I want to point out is this, okay, this abnormal screen box, we changed that to say critical screen and make it much more clear. So there is a designation between the abnormal, critical, and normal screen. So that's just kind of an example I wanted to show you about like how this kind of has evolved over time and how the user's feedback really does, I think, improve and drive the process forward. So just to so you can kind of see, this is where we're at currently. This is the cystic fibrosis report that we have kind of after the interviews with the providers. One thing I do want to report out is that one of the big things that we did sort of like, add to and clarify is in this kind of recommendations language in the results section. So we really wanted it to be consistent with the updated cystic fibrosis guidelines, which Marcy kind of went over that a little bit in the beginning and kind of spoke about how those have been recently updated. And we wanted to make sure that was most up to date and consistent and clear about really the language with like 1 mutation versus 2 mutations, and hopefully facilitate that process a little bit better. Okay, so that's really all I have for right now. I wanted to again thank the team that I worked with, because that really made this project such a success, and it just was really a joy to work with all of these people. So I want to thank everybody for that. And again, thank you for having me here today.
Michele, thank you so much. This was great presentation, so well delivered and such great information. And thank you to your whole team who worked on this. Really very much appreciate all of your work. And I would love to open it up for questions. We will monitor the chat box if you'd like to type your questions in. I'd just like to emphasize the importance of the timing of this. It's remarkable that you were doing this just as the new CF guidelines came out. I think there's a lot of states, much like Virginia, who are considering going to sequencing. And for those of you who don't know, I forget if you mentioned this today, Michele, but Virginia just started sequencing for CF. So figuring out how do you best share those results with the newborn screening or with the pediatricians is so critical. So really emphasizing the time. Mel, good to see you. Please come off mute and ask your question.
I have 2 questions. I have a question and comment. If you could go back to the second to last slide with the abnormal and the critical screen.
Wait, this one?
Yes.
Okay.
So if you just have because I know this is for like the mucopolysaccharidosis, but if you just had a patient with a single mutation who needed a sweat test, they get the abnormal screen. The critical screen is only for those patients that you've identified 2 mutations.
No, Mary, you might want to, if you want, you can chime in here too. We have a separate template for 1 mutation too. I just presented a 2 mutation. Do you want to add anything else to that, Mary?
So that one would say critical or abnormal?
I'm sorry, Mel, do you mind repeating your question for me?
Yeah, no problem. So this critical screen I assume, is a child with 2 CF mutations, right?
Correct.
So if the child just has 1 CF mutation, what is the screening result labeled as?
Do you put if I'm understanding correctly, do we put critical screen up in that box, or do we put abnormal screen in that box?
Or Marcy's smiling because she wants you to put normal.
Yeah.
If you've done all your sequencing.
No, so if we're talking about our current panel that we just went live with, which is the next gen sequencing, if it's a single mutation, we still list it as abnormal.
Okay.
Because
We do too.
Oh, yeah, because I mean, I know that everyone joining this call knows this, but you know, there's still the potential to have CRMS. We had a child recently who had a single mutation on our previous panel when we were using the terminology mutation to remain in alignment with our laboratory team. They had a single that was noted. Expanded genetic testing was done by the CF provider. It was found that it was just one. They were diagnosed with CRMS following their sweat test. And they just recently, we've had an updated diagnosis for CF. So we're still listing, yes. So we're still listing it as an abnormal result because there is the potential.
The other comment I had, and I'm not a geneticist at all, but I do find the phrase the presence of a minimum of 1 homozygous variant confusing, because I always think of that you need 2 mutations to have CF. I know this is proper English for genetics, but I find it confusing. I don't know, maybe your panel didn't.
I think that's a great, example of I don't think I brought this up, but the tension between, we have multiple users, right, that receive the same
I'm a
report, right?
pulmonologist, so that's my
Oh, good. Oh, good. Okay.
Just so
So,
you
yeah,
know,
so,
like of your multiple users, I would be CF center personnel.
Right. And so, the pediatrician gets this, and somebody who's a specialist, right? And it's, and potentially family members. So they're like individuals that, and patients. So that's why we sort of asked as part of it in the end, like, what do you do with their support? And one of it was, what do you share this with families? And it's mixed, some people do. And I think that's the challenge that we decided is well beyond, it's like beyond the scope of this, like kind of one project, but ideally you would have 3 separate reports designed for the 3 different users, because what we're trying to do is fit information for 3 people that have 3 different, backgrounds, skill sets. They're even just using these for different things. And we're trying to fit it all in on one report and make it work for all the different people. But I think that's a perfect example of why this is still work in progress. And
yeah, like I 100% like know what it means, but just from calling pediatricians or seeing kids who get sweat tests, it didn't even need sweat tests because I don't think they understood what we said. Like, it's a negative screen, right? Even though the IRT was high, it's a negative screen. They only had 1 mutation. But I really love this. I love how it says critical screen. I love how it says this requires immediate attention. I think that's like really eye-catching to the pediatrician. It doesn't look like all the other lab results that come through. It's really great. I'd love to steal it, to be honest.
No, Beth needed. We're happy to share templates with anyone. So feel free to reach out and we will share them with you. Another part, I see some of the comments in the thread. It is really, really difficult because we want to provide that education at the same time. And there's so many different differing understandings of terms, and we don't want to change things too rapidly because it's just another factor from state to state, but what we call our results are very different. They could be presumptive positives. They could be, as we do here in Virginia, abnormal or critical. So that is deeply ingrained. We're trying to stay there while also updating our other language like variant versus mutation. And this is that notification form saying, we have, verbally reported this result to you. This is your notification of what it is, what you need to do. But it's not the only thing we're sending out. We're also sending 2 additional pages after this that are education sheets that provide more of that information for the providers. So that way it helps keep the focus on what's most relevant on the first page, and then they get the rest of it after.
Yeah, Mary, I love that. Because this is it gets your attention. Make sure you follow this, and then please read what's next. Like, here's some other additional information for you. I want to make sure we get to the questions in the chat. Jennifer Gorowski from North Carolina asks, I know it was a small sample size. She asks about, did you meet saturation, and if it would be worthwhile to add in other providers, nurse practitioners, PAs, family practice.
We did reach some saturation on some themes. I did different types of analysis. I think a lot of the design and format stuff we did for sure, but I think, again, if you could go back and do everything different, I would like to interview more pediatricians. I think that probably would have been,
I guess
that would be something we'd like to do.
The other question then, Michele, is many times in practices, it might be a nurse practitioner or a PA that's seeing it. And I wonder if they have different feedback as well. So there's always,
I'm sure they do.
Yeah. I also want to point out that there's maybe the most important comment in the chat is that Allie really loves your dog, Mel. And so your dog has gotten a lot of love today in the chat.
I'm glad he was able to come.
Yeah, Sylvia.
Yes. Well, thank you so much for this. This is very useful. I'm in Ohio, and we are, in the collaborative, and Marcy came, so that was great. So this is very useful, and I think we're trying to change the verbiage in our forms now, and one of the things that I see, the fact that it says critical is so useful, I think. And that's something that I'm going to bring to my group, definitely. So I'm taking this from here. And the other thing is our newborn screening only says IRT. So many times the families, when they see the result, or even some pediatricians, don't know that with the IRT, we're referring to the screening for CF. So having it there is also very useful. So I do see a lot of good things. And the question that I have is, do you send a page for every single disease that you test? I mean, we're trying also to make it one report, and our report includes, the 12 diseases that we test in one page, and then the next steps. But from what I'm seeing here, I see 3 pages, but I don't know how we will look for a patient, because, more pages will make it more confusing for the families and for the recipient of the test. So I don't know how you guys navigated that.
We do send the cover sheet is specific for each condition. And yeah, that ended up being a lot more work than we anticipated. That's where Kelly, I think I pointed her, and Anne were amazing. But I think that is right. I think your point about people read the first page and do they read after that? Mixed. But there's multiple pages, there's multiple things that are sent along with this, the fact sheets, other information. So that is a challenge that we are aware of, and I don't think it was beyond the scope of this little project, this part of the project at least.
Yeah, can I jump in? I had my hand raised, but it's a similar question, right? So, and I was just going to clarify that this is not the standard report that goes back to the submitter of every sample. This is a specific report for follow-up purposes. And that's the distinction I wanted to make, right? Because a lot of this content and a lot of the thoughts on this also need to be included in that standard report that goes back to everybody, includes all the, all the disorders that Sylvia mentioned, So yeah,
This
that's
is
just
not the report that comes from the lab. They also receive the DCLS report, like the report that actually is from the lab, which is also very confusing for the pediatricians. A lot of them did not realize there's actually like this is sort of like the notification of that there is of the screen, not the report that comes from the laboratory that does the testing. And there was confusion about that. Sorry, go ahead.
Sorry, Michelle. And if I may, the purpose of this report has there's another function of this for Virginia newborn screening, which is to encourage the return of results for follow-up. So we also had to contend with making it clear that there was an expectation of returning of returning information back to the program. And so balancing, like, this is a notification to a provider that action needs to be happening, but also that the follow-up program is going to expect those results back, and that they need those results to make sure that they can close the loop. So we tried to make sure that all of that information was on this one page. And not to rely too heavily on additional pages.
Thank you, Anne. I think that's very helpful. Excellent. There's a question in the chat that I think I can probably answer for you, Michele, about is this work published? And it's not published yet because they're still finalizing all of this. But knowing this group of researchers in the Virginia lab, I anticipate that it will be published with time once they get the final version out. Is that correct, Michele?
That is correct. And I think Mary mentioned this, but like, this is like, we want to share this with people. This is not like, secret. Like, you don't have to, take a screenshot and try to change your own report. Like, please contact anyone from the team. But I think Mary's probably, sorry, Mary, if you get like 300 emails, but Mary is the best point of contact for that, I think, at this point. But yes, yes, we want people to use these ideas and improve on them, and this to be like a collaborative process moving forward too. But yes, we do plan on publishing.
Ashley's reminding us there was a poster last year at the symposium, so thank you for that, Ashley.
That's true. Yes, thank you. Yes.
So we will share these resources for sure and continue to, get updates as you continue to update the final report. So this is fantastic. So one last question, because there's so many questions here about all of these things. Remind me, are preliminary reports still being sent out now that you've changed to sequencing? So those that are marked abnormal, if you're waiting for sequencing, what's happening with those preliminary reports? And Mary, that probably is a question for you, if you can answer that.
Yes. So, hey, Lauren, the preliminary reports are still going out, and that's one of the differences that Michele highlighted. So preliminary reports are something that are sent out by our laboratory team with our Division of Consolidated Laboratory Services, DCLS. So they have their full report for the entire panel, for our Virginia panel. And when there are preliminary results, being that IRT is elevated and we're waiting on the sequencing results, but everything else has resulted, they'll go ahead and mail that out as a preliminary to the identified providers on the sample card that we receive. So that way they're aware of anything else that requires, follow-up, or they're aware of the other within normal limits results. And it's an early heads up that, hey, sequencing is being performed, and then follow-up will be in touch with you regarding the results. So that gets mailed out. And then when we have finalized results, not only is the finalized report mailed out again by our laboratory team, but the results are then reported out by our team, whether they are single mutation or double mutation being critical results.
Excellent. Well, thank you so much. I want to move to some additional resources that are available. But first, I just want to really heartfelt thank you, Michele. This was fantastic. And for your whole team, we very much appreciate all of the work that you have done. And there's been a lot of questions in the chat about sequencing, and I'll get into that a little bit more with our additional resources and some additional conversations we'll be having on future webinars about sequencing as well. So thank you first, Michele, that was amazing. As we're thinking about the education of individuals with individuals who receive newborn screening and just in general, I want to point out some work that has been done by Susanna McCauley's group under her leadership at Lurie Children's Hospital in Chicago. And these are also freely available. So these are some resources that were funded by the CDC to really look at and support the education following newborn screening and equity related to cystic fibrosis. So these have been developed through this QR code, and the link that's in the chat will help you if you wanted to customize this for your own state, your own hospital. You can do that there as well. So this is a great resource. Here's one for CF, and then the next slide is one that is for all newborn screening results. So those are freely available, and really thank Susanna for your leadership on this to help us be able to share these more broadly. Next, I'm really excited to announce Cystic Fibrosis Genetic Resource Centers. This is an initiative funded by the Cystic Fibrosis Foundation, in which both the Wisconsin State Laboratory of Hygiene and the Wadsworth Center Newborn Screening Program in New York State will be offering assistance with sequencing for CFTR. So if you are interested in this, we're happy to share more information with you. You can get information on our website. There's also, we'll be sending out more information shortly on the listservs, but they'll be offering panel-based genotyping. You can be looking at variants of varying clinical consequence, the VVCCs. You can do various different things. Or if you say, you know what, we're close to being able to do sequencing at our institution, we need some technical assistance, they will also be available for that. So this is a really exciting opportunity for us to help programs who are ready to move towards sequencing and just don't quite have the resources or capabilities yet to help you get there, either by sending your specimens to New York or Wisconsin, or by doing it in-house and getting additional technical assistance from those programs as well. So with that, our next offering in our webinar series will be on May 1st. You can get the QR code here. And there's also a link that's just been placed in the chat that we encourage you to register for that. It's very similar to this series today, or it's the extension of this series, where you can learn more about what New York and Wisconsin are offering. So we encourage you to do that. Further down the road over the summer, we'll have additional webinars on talking about how do we do these callouts. Are we going to do one variant? You can calling one variant out as a carrier, one variant out as an abnormal newborn screen. Those are all really state-based decisions that you each need to make. And so we'll be having some discussions about that as well as IRT discussions, communication challenges, etc. as we move through the rest of the year. I also want to highlight our newborn screening collaboratives. We will have collaboratives starting in May, and this is kind of a kickoff for this new round of collaboratives. Many of you participated in our collaboratives over the last year or two. We're restarting them now, mixing up the groups and encouraging all of you to join. So we encourage you, if you haven't already joined or listened into our informational webinar yesterday, please join next week. We would love to have you then to hear about what we plan to do with these collaboratives. These are really meant for state teams of CF newborn screening programs and CF centers to join together and work on tackling problems small or large. It could be looking at your IRT cutoffs or sequencing. It could be looking at education or communication, or it could be looking at other things as well. So please join us next week for that if you haven't already. And so here's our email for our CPHI team. Please feel free to reach out to us. We would love to hear from you. And our resources are now highlighted on this top website, that our CPHI website with a CF subpage that gives you all of the information that I just shared. And so with that, I would like to thank you. Special thanks to Michele, and Yvonne, looks like you have something you'd like to add.
Yeah, I've just been chatting with Mary, and so we don't flood her inbox. CPHI is going to work with her to kind of get everything out, so you don't need to all individually email Mary. Let us work with her, and we'll get things out to people.
Thank you so much, Yvonne. So thank you to the Virginia team and to Michele and Beth and Anne and your whole team. It was so great to hear about this. I think you sparked lots of ideas for all of us. So thank you so much for sharing, and have a good rest of your day and a great weekend, everybody.
Thank you.